Recording in progress.
Good morning, everyone. I am Dr. Pallavi.
Audible. Ma'am, audible, ma'am.
Is it audible?
Yes.
Okay.
So, good morning, everyone. I am Dr. Pallavi, Assistant Professor from Kaya Chikitsa Department, and I am delighted to welcome you all for today's webinar on the topic of Ayurveda and Thyroid Management. So, organized by Department of Kaya Chikitsa, Rajarajeshwari Ayurveda Medical College, Humnabad. It's great to see all participants joining us for today's webinar. So now I request Dr. Gaudampalli Gayatri Madam to introduce about our guest speaker, Dr. Priya Bhat Ma'am. So,
Thank you, Dr. Pallavi. So, good morning, everyone. A warm welcome to all the participants joining us today for today's webinar on Ayurveda and thyroid disorders, a comprehensive review with case studies. It's indeed a great honor and privilege to introduce our esteemed speaker, Dr. Priya Bhat Ma'am, an eminent scholar, dedicated teacher, and compassionate clinician in the field of Ayurveda. Ma'am has completed a BMS from SDM Institute of Ayurveda, Udupi, and her MD from Ayurveda Medical College, Mysore, Government GMC Mysore. With over a decade of teaching and clinical expertise, she currently serves as an associate professor at SDM Institute of Ayurveda and Hospital, Bengaluru. She has guided numerous PG scholars and is also a member of Board of Postgraduate Studies at Rajiv Gandhi University of Health Sciences. Ma'am also serves as a reviewer for the International Ayurvedic Medical Journal, IAMG, a reputed peer-reviewed publication. Ma'am has several research papers and case studies published in reputed national and international Ayurvedic journals, covering a wide range of clinical areas such as neurological, urological, endocrine, and musculoskeletal disorders. Our approach beautifully integrates classical Ayurvedic wisdom with modern clinical insights, making our session both enlightening and practically relevant. We are truly privileged to have her with us today to share her valuable knowledge and clinical experiences on the management of thyroid disorders through Ayurveda. On behalf of everyone from Rajarajeshwari Ayurvedic Medical College, Hospital, and PG Center, I extend a warm and heartful welcome to you, ma'am, and thank you for taking the time to enlighten us with your expertise. Now, without further delay, let's all warmly welcome Dr. Priya Bhat, ma'am, to begin today's session.
Thank you, Dr. Gayatri. I hope I'm audible to you all.
Can we start, ma'am?
Yes, sure. So I'll be sharing the slides.
You start sharing the screen.
Yes. I hope the screen is visible to you all. Am I audible? Okay. So today's topic, so welcome you all to the webinar. So my topic is today, I'm going to speak on Ayurveda and thyroid disorders, a comprehensive review with the case studies. So let us briefly understand what exactly is a thyroid gland. So I think you all are familiar. So let me just tell you, it's an endocrinal gland, which means that it secretes a few specific set of hormones, which has a few specific set of secretory cells basically producing those hormones, and it is located in the anterior part of the neck, so producing the hormones T4 and T3. And the T4, these days,
Sorry to interrupt.
why?
Just a second. Ma'am, just a second. Sorry to interrupt you. I think there is some disturbance in the audio. Just a minute, ma'am. I'll just.
Okay, yeah, sure.
हो 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 ठीक आहे. हो ठीक आहे ठीक आहे. हा, चालेल. युट्यूबची आयडी आणि सगळ्याची आयडी पाठवला मला, तुम्ही पाहिजे तर चेक करून घ्या.
Somebody will be listening.
You, anybody come just come.
I should not.
About your first, you only have to know about all these things.
तुझा म्यूट
म्यूट नाही झालं.
Ma'am, you can start.
Okay, so I hope it is audible now. Yeah, okay. So going ahead with the topic as such, I have told you it's a butterfly-shaped endocrine gland situated in the anterior part of the neck.
You can start.
Yeah, it's situated in the anterior part of the neck. So it regulates plenty of functions in the body, primarily dealing with different metabolisms in the body. May it be glucose metabolism, may it be lipid metabolism, growth, development. So plenty of functions are basically under the control of the thyroid hormones. So why the thyroid disorders have been a talk of town recently? That is because of the large amount of the incidence rate, what you see. So at least globally, if you see around 42 million, this is the estimated amount, of course, 42 million people in India are currently suffering from thyroid disorder. Globally too, it's in a very large in number. So with this incidence rate, you can see that a large population being affected from the thyroid disorders. And this is just the number which are reported. There might be plenty of cases which may go unnoticed or unreported cases as such. So this is the large scale in which the thyroid disorders, may it be hypo or hyperthyroid cases, which you can note in India as well as in the worldwide. Hence, it is relevant for us to discuss how to manage this disorder effectively. Moving on to the state-wise incidence rate, if you can see, especially the South Indian states are more affected with these thyroid disorders, both hypo and hyperthyroid. Now, moving on to the risk factors. So let us understand why exactly such a large scale of population is basically affected with the thyroid disorders. So primarily, we can see that there is genetic predisposition. So a positive family history, So gives or rather multiplies the or rather increases the chances for getting the thyroid disorders at least by 5 to 10 times fold. So there is that is why you see that in recent years, because of the positive family history, large number of cases being multiplied, and you can see plenty of cases being registered with the thyroid disorders. And any history of past autoimmune disorders. So one autoimmune disorder can generally trigger the presence of other autoimmune disorders. That is why you see plenty of, either the Hashimoto's thyroiditis cases or the Graves' disease cases being reported recently. And history of, any iodine imbalances. So specifically at places with higher altitude where iodine deficiency is noted, you can see that the chances of having hypothyroid cases are quite higher. So that is why, as per the National Goiter Control Program, iodine mixed salt is provided since 1986. Despite that, you might find that plenty of people not using it may lead to cases of hypothyroid being noted. And along with that, you can have a long history of medication, either radiation exposure, chemotherapy exposures, or certain mood stabilizers like lithium or the antiarrhythmic drugs used for a long term can interfere with either the production or the metabolism of the thyroid hormones. So all of this can increase the risk factors for the production of the thyroid disorders. Now, let us just look into briefly the functioning of the thyroid hormones, or rather production as well as the physiological part. So without which probably understanding the pathology will become a difficult task for us. So we all know the controlling part is basically for the thyroid gland would be the hypothalamus and the pituitary. So the hypothalamus initially produces the TRH hormone, which is nothing but the thyrotrophin releasing hormone, which stimulates the anterior pituitary gland to produce the TSH, nothing but the thyroid stimulating hormone, which further stimulates the thyroid gland to produce the T3 and T4, which are the, among which the T3 is the most active form of the thyroid hormone. The T4, which is basically produced by the thyroid gland, is also later on converted into T3 in the liver, and later on basically pursued by the different target tissues and the organs for their respective functions to be delivered over there. So all of this production being basically controlled by a mechanism, a beautiful mechanism called as negative feedback mechanism. So that is why you see whenever you subject a patient with the thyroid disorders for the thyroid profile test, you might find a few of the precursors being altered. So that is basically because of the feedback mechanisms. So whenever you have the T3 and T4, basically there is a hyperproduction of these hormones, less production of these hormones. Because of this mechanism, the thyroid gland sends a signal to the precursor glands, that is the pituitary or the hypothalamus, stating that there is less production of the T3 and T4. Hence, whatever precursor hormones which has been basically supplied to be sent in a large quantity. So that is why either the pituitary as well as the hypothalamus produces the or rather sends more set of precursor hormones, thereby producing the sufficient number of T3 and T4. So this mechanism is called as negative feedback mechanism. Hence, whenever there is a hypothyroid case, you'll find that the initial levels of T3 and T4 being managed because of the large amount of the TSH being supplied by the pituitary. So that is why a thyroid profile will show you that the TSH values will be increased and T3 and T4 will be maintained for a brief period. But when uncontrolled for a very long period of time, obviously, even the T3 and T4 levels are also going to drop down. So similarly, when you have hyperthyroid, so the feedback will be sent to the precursor gland, saying that the TSH is produced to be sent in less numbers so that the T3 and T4 levels are maintained. So that is why the thyroid profile, when being done, you will find that the TSH values will be very less and T3, T4 maintained in the initial phases of the hyperthyroid cases. So this beautiful mechanism basically maintains the balance during the physiological aspect, and even during the pathology, the initial phases will be effectively managed because of the feedback mechanism. So now let us look into how the synthesis of these hormones are going to take place. So just let me just explain you briefly. So we have a very required substrate, or rather the raw material required for the production of the thyroid hormone in the form of iodine. So that is why iodine is very crucial for the formation of the thyroid hormones. So whenever there is a oral intake of the thyroid, rather the iodine molecules, they are going to basically circulate in the bloodstream. So initially there'll be tapping of these iodine molecules into the colloidal structures, or rather the follicular structures of the thyroid gland as such. So once they get inside the thyroid gland, they are going to get oxidized so that their active form is available for the absorption. So next, the very important molecule which is required is the protein molecule found in the colloidal structures of the thyroid gland, that is the thyroglobulin. So these thyroglobulin situated in the colloidal structures of the thyroid gland basically have a very active form of the protein called as tyrosine. So this tyrosine basically clubs up with these iodine molecules, so to form monoiodotyrosine and the diiodotyrosine. So one molecule of iodine mixing up with one molecule of tyrosine produces the monoiodotyrosine. One molecule of iodine combining with two molecules, two molecules of iodine combining with one molecule of tyrosine produces diiodotyrosine. So these monoiodo and diiodotyrosine combine together, so to form the T3 and T4 together. So these T3 and T4 later are going to form a lysozyme, and when these lysozymes cleave themselves, then there will be release of the T3 and T4. They're going to further released into the bloodstream. So as I mentioned earlier, T4 is not the active form. T4, when enters the liver, is basically there's deiodization of these molecules, later on forming into T3. So the T3 is the most active form, which is basically circulating in the bloodstream, and later on accepted by the receptors in the various tissues to produce their respective functions. So let us just briefly look into the functions. So whenever there is any alteration in the hormone production, the respective values are going to get affected. So there are different set of functions being produced at various organs. So you can see that in the brain, it is going to affect the cerebral circulation as well as affect on the cognitive functions, mood functions also. So in the heart, it is going to basically manage the circulation of the heart as such. So cardiac functioning is basically controlled under the control of the thyroid hormones. In the pancreas, it is going to manage the insulin production, its sensitivity, and in the liver, it is going to once again look into the lipid metabolism, the glucose metabolism, and so on. And in the adipose tissue, it is going to maintain the lipid metabolism. Skeletal muscle, which is once again a major sink for storing the glucose molecules. Once again, the glucose metabolism is under control over here. Skeletal structures as such, if you see the bone homeostasis, that is either the osteoclast and osteoblast functioning, is basically under the control of these thyroid hormones. So even the body temperature regulation is also under the control of the thyroid hormones. Digestion functions, as I told you, various metabolism, even the digestion process also is under the control of the thyroid hormone. So you can see that a varied set of functions are basically kept under the control of the thyroid hormones as such. So whenever there is any hypo or hyperproduction, there is alteration in these functioning of the thyroid hormones. Now moving on to the main topic, the thyroid disorders as such. So you can broadly classify thyroid disorder, one in the form of the functional abnormality, second in the form of the structural abnormality. So let us just look into the functions of the thyroid hormones. So either the function of the thyroid hormone is in the form of euthyroid state, that is normal set of hormones being produced and normal functioning of the thyroid gland being seen, which is a physiological aspect in the body. Then in terms of the pathological aspect, you have either hypofunctioning, which is nothing but the underactive the thyroid gland, or there is something called as hyperthyroid stage, which is nothing but the overactive thyroid gland. Both of these two are the pathological presentation of the thyroid hormone functioning. So we have a different set of disorders which basically presents in the form of hypo and hyperthyroid disorder. So you have a few of the autoimmune disorders which will be basically leading into this presentation. Iodine, either hypo or increased intake leading into different disorders, congenital abnormalities, and secondary thyroid disorders, that is either pituitary or the hypothalamus disorders, basically presenting in the form of the hypo or hyper functioning of the thyroid glands later on. So a secondary presentation, these can also lead to the hypo or hyperthyroid disorders. So let us just try to restrict ourselves first to the hypothyroidism or the hypofunctioning of the thyroid glands and look into what exactly are the causes and how it is going to present into. So as mentioned earlier, hypothyroidism is nothing but where you can see that the gland is unable to produce the sufficient number of T3 or T4, which may be either because of the hypofunctioning of the thyroid gland in itself or its precursor hormones not being supplied in a normal rate, leading into insufficient thyroid hormones. So this can eventually lead to the very slow or lower metabolic rate, what we call it as basal metabolic rate being reduced. So you're going to find a different set of symptoms pertaining to lower metabolic rate in these patients. Now, let us just look into the incidence rate. So globally, you have at least 5% of the global population, especially with the women over 60 years suffering from these disorders. And Indian incidence, if you see, at least 10% of Indian population is basically suffering from the hypothyroidism. So this is a large scale of population basically going. As I've told, this is just a reported case. You might have plenty of unreported cases as well. Look into the pathogenesis. I've told you this is irrespective of the cause for the hypothyroidism. I'm telling you that there is reduced level of T3 and T4 leading into lower metabolic rate. And whenever you subject such patients for the thyroid profile, you'll find that because of the negative feedback mechanism, the TSH levels will be raised because body is trying to send a signal to the pituitary to produce more amount of TSH to compensate the lower levels of the thyroid hormones, what is being basically produced by the thyroid gland. Now, let us briefly look into the causes. So the primary cause, you can basically classify it as primary and secondary causes. So primary causes are basically wherein the thyroid gland in itself is not functioning in a proper way. So you have something called as Hashimoto's thyroiditis, which is an autoimmune condition. So then you have iodine deficiency, because iodine is a substrate which is basically required for production of the thyroid hormone. So whenever there is an iodine deficiency, the production is also going to get affected. So especially at a place of higher altitude, you're going to find this iodine deficiency. Then you have a post-thyroidectomy state where because of maybe a malignancies or a very large benign tumors. So post the thyroidectomy, you're going to find that the secretory cells are not present to produce the thyroid hormone. So there'll be hypothyroidism, which will be noted. Then you have either chemotherapies or radiotherapy, especially the radiotherapy, where the cells, the secretory cells of the thyroid gland in itself are basically destroyed, thereby the production is going to get affected. Now, moving on to the secondary causes, you have the precursor hormones or the glands being affected, primarily a very large benign tumor in the pituitary gland, which puts up a pressure on the secretory cells, and hence the pituitary secretory cells are not able to produce the TSH. Or you have hypothalamic disorders, once again, where maybe most of the time it's a tumor, which basically puts up a pressure on the secretory cells of the rest of the other secretory cells of the hypothalamus. Thereby, it is unable to produce the sufficient number of the hormones by the TRH hormones, and thereby subsequently the TSH and the thyroid hormone production is going to get affected as such. Okay, let us look into the first major cause for the production of the thyroid hypothyroidism as such. It is the Hashimoto's thyroiditis. So in Hashimoto's thyroiditis, you can see that generally most of the time it is a viral or a bacterial infection which basically stimulates this disorder. So there is either most of the time a respiratory, a viral or a bacterial infection, so which acts as the precursor. So post this infection, you can find that the body's immune system, immune system is required in the body to fight against any infection. But right now, in such a patient, there is a hyper accelerated immune response, which produces an autoimmune attack on especially the thyroglobulin, the protein component in the follicular cells of the thyroid gland. So because of this, the activated CD4 cells and the T helper cells, as well as CD8 cells, which puts up a the hyper-exhalated immune attack on the thyroglobulin destroys these earlier normal healthy cells, and thereby there is reduced number of healthy available secretory cells in the thyroid gland. Hence, the production is going to get affected. Now, the interaction between these thyroid, the cells, follicular cells, as well as the CD4 cells or the CD8 cells and the T cells basically puts responsible for the goiter formation. That's the inflammation is going to lead to the swelling at the localized site, and thereby you can find that there is goiter formation in the thyroid gland. Now you can see that the signs and symptoms are nothing but the reduced basal metabolic symptoms. So every organ which is basically get stimulated by the thyroid gland, there will be hypofunctioning seen in these organs as such. So you can see that the fat storage is going to get increased. So there will be weight gain. As you can see, the body temperature will be reduced. So cold intolerance will be there for the patient. You can find that the sweating is going to come down. So patient will have dry skin as a presentation. The gut motility is going to get affected. So constipation will be there. Mood changes will be there. So depression is going to present. Cardiac activity, rather the pumping activity is going to get reduced. So there is low heart rate. Overall, patient is going to have fatigue, weakness, myalgia, and very vague set of symptoms. Hence, at most, suspicion is required for you to diagnose the hypothyroid case as such. So when this whole condition is not being treated for a very long period of time, or even when poorly treated, can lead to a complication called as mixed edema coma, where there will be severe hypothermia, severe lethargy, the respiratory rate is going to drop down severely, cardiac functions is going to drop down severely, and patient may enter into a stage of even coma also. So hence it is very crucial for us to detect it at a right phase and treat it effectively, and not neglect such cases as such. So when moving on with the investigations, so primarily you have to go ahead with the blood test. So you have to go for the thyroid profile. So initially, as I told you, the T3 and T4 levels may be managed effectively because of the feedback mechanism, but later on, even that levels may also drop down. So TSH is obviously going to get increased here. So that's a right factor for you to determine that it is a hypothyroid case. And most specifically for the Hashimoto's, we have anti-thyroid antibodies or thyroid peroxidase test, which is going to be positive, or the values are going to be reduced, which gives us a clear idea that it is a Hashimoto's thyroiditis case. And then on, you can also go ahead with a few ultrasound tests of the thyroid gland for you to specifically differentiate whether what sort of a goiter it is, whether there is any malignancies associated with that, or to differentiate any of such pathologies, you can even go ahead with the ultrasound of the thyroid gland also. So looking at the complications, specifically if you have cardiovascular complications, you can expect, because there will be fat metabolism which is being affected, atherosclerotic changes may be seen, thereby blood pressure and certain cardiovascular complications may be an end result because of these unmanaged thyroid disorders. Then, as I mentioned earlier, mixed edema coma is also one of the life-threatening condition which can occur because of severe reduced metabolic rate. And primarily, you can also look into cases of infertility being registered because of hypothyroidism. So either infertility, or even if conceived, miscarriages might be there, repeated miscarriages. And even during pregnancy, if hypothyroidism is not treated properly, then you can expect either a preterm delivery, or more so specifically with the cognitive decline in the infants, or different developmental delays which can occur. So whenever in pregnancy, if you find there is any hypothyroid cases, treat it at the earliest, because two lives are at risk when such a complication is seen in the in patients. So whenever you have, so I have highlighted here only with the Hashimoto's thyroiditis, because of course, iodine deficiency, the similar set of symptoms will be there, but INF management is primarily dependent upon managing the iodine values. And whenever you have secondary hypothyroid cases, then you have to manage the precursor glands. Only then you can get results with the managing with the thyroid hormones. And whenever you find that any other systemic features are there, respective management principles have to be applied, as well as whenever there is post-thyroidectomy and radiation causes, which has been mentioned for the primary cause. So since the secretory cells in itself are destroyed, your role as an Ayurvedic physician becomes limited, because probably the hormone supplement may have to be done to manage such cases, because even if you try to stimulate the thyroid gland, there are no secretory cells to produce the right set of hormones which are required right now. Now let us look into the Ayurvedic view of how to assume the or rather look into the conditions of the hypothyroidism. first, of course, every metabolism in our body, we have been, repeatedly probably trying to understand the functions in the body being determined or rather understood in the form of the function of the Agni. Now, Agni, you all know, is understood either in the form of both the Jatragni, Bhutwagni, and the Datvagni levels as such. Now, though Jatragni is considered being restricted for the metabolic, primarily the gut metabolism as such, you have the Bhutagni and Datvagni, primarily, especially the Datvagni, which is understood in the form of functioning of the, the levels of the systemic functions, or rather in the form of cellular functions. So every metabolism in the body is basically understood in the form of Agni. And whenever there is any hypofunctioning seen in the Agni, you can expect that the metabolic functions, various metabolic functions in the body are going to get reduced. So this can be attributed to the hypo functioning of the thyroid gland as such. See, let's look into the Lakshanas told in the Charaka Chikitsa Sthana, especially the Grihini Adhyaya, where he tells about the Agni functions. So that Ayu, Bala, Varna, everything, Swasthya as such is being basically controlled by the Agni. So whenever there is any Agni Dushti, you can expect that there is Utsahahani. Okay, lethargy and hypofunctioning being seen in the body, you can expect that the dehagni being reduced. That is the body temperature being reduced. And when not very well kept under control, even it can lead to pranahani also. So any complications, life-threatening complications, what you can expect because of the Agni also being mentioned over here. Next, you have a few other conditions which may basically come up with the similar lines, that is the rasa dushti. So whenever there is agni dushti, you can expect the first dhatu being affected, that is the rasa, and the agni, the adyahara rasa dhatu, or what in itself feeds the rasa dhatu. So whenever there is any alteration in that, even rasa dushti is also going to occur. And the Dhatwagnis, as I told you, the Jatragni basically controls the Dhatwagni. So you can expect the Rasadushti being seen over there because of the Rasadhatwagni being affected. So one of the condition quoted as Kafaja Pandu, reference from the Charaka Chikitsa Sthana itself, which quotes as that whenever there is Kafaja Pandu or Rasadushti, you can see that the patient is going to present with the Gaurava, there'll be Tandra, so Angasada, Klama being explained, and Alisya being explained. All these symptoms you're going to find whenever there is hypofunctioning of the thyroid gland. So this is also one of the condition which you can closely mimic to that of the hypothyroidism as such. The next condition, what you can see, since there is goiter formation, you have one more presentation which is being quoted at multiple instances, both by Charaka and Sushruta. So where I put up the Sushruta Nidana reference, where it says Galaganda, where because of the Vata and Kapha presentation, along with that of the Medu Dushti taking place, leading into the presentation of a goiter, or rather a growth-like presentation seen in the Manya area. So this is exactly the understanding, or rather the description seen with the goiter formation also. So this too can be considered in terms of structural presentation, which is seen as one of the symptom in the patient of hypothyroidism. So functionally, if you see the Agni Dushti or Rasa Dushti can be taken into consideration, and structurally, if you see the Galaganda or the goiter presentation can be taken into consideration as such. So if you have to manage a hypothyroid case, so then probably in terms of the functioning aspect, you have to, so you have to look into the improving the Agni functions, managing the, or rather reducing the kapha and the medas, along with regulating the vata. So this is exactly the principle behind managing the hypothyroid case, irrespective of whether it is a Hashimoto's case or the other case. So more so specifically with the Hashimoto's case, since it's an autoimmune condition, Agni plays a very important, because Amalakshanas are the one primary being pathology being involved into its presentation. So once again, coming to back to square one, Agni Dushti is the primary cause. So Agni to be corrected, which is the first and foremost principle in managing the even the autoimmune thyroid disorders as well. So grossly, we can understand in the form of you can either go with the Shodhana Chikitsas when required. Initially, of course, go ahead with the Agni Dipana Pachana, followed by the Shodhana Chikitsas. So Vamana would be the best line of management principle for the hypothyroid cases, because it is going to target the kapha. So you can do the Arohana Matra Snehapana with the help of the Varunadigrita, and then go ahead with the Vamana with Madanaphala with the required dosage based on the Vala, Agni, and the Y of an individual. You can take a call on to what would be the dosage. And then, if not, even Virechana principle can also be done, because it manages all the three doshas. Does Vatanalomana, Pitta Rechana, and Kapha also. Kaphanta Virechana has been told in the classics. So, if you do a Samyak Virechana, even that is also going to help in managing the hypothyroid cases. Now, moving on with the Shamana line of management, because clinically, probably not all patient may be willing to go ahead with the Panchakarma therapy. So, as a Shamananga, we have to go to think about plenty of medications which you can prescribe based on the underlying complaint. So, you can go ahead with the Kanchanara Gugulu. Kanchanara is plenty of studies are there to prove its efficacy on the management of the hypothyroid disorders, and as well as it also is effective in managing the goiter presentation also, because Vata, Kapha, and Meda is being involved. So a apt line of management would be advising the drug of choice, rather we can say, would be in terms of Kanchanara Gugulu administration. And then, since Agni to be corrected, you can go ahead with the Agnitundi Vati, Chitrakati Vati. You can also go ahead with Varunadi Kashaya, because Varunadi Kashaya helps in managing the Agni, managing the Vata and Kapha Dushti as well. So, Varanadi Kashaya is one of the best prescription what you can give. Hamsapadadi Kashaya, once again, similar lines of management, just like Varunadi Kashaya. You have Puranavadi Kashaya also, which is effective, acts on a similar grounds. It has Dipana, Pachana, and acts on Rasa as well as the Kapha. Puranavadi Kashaya is good for managing the Rasadushti also. So you can advise Puranavadi Kashaya also. Ashtavarga Kashaya, once again, does Dipana, Pachana, and Kafara function is also seen. You can advise Pipali Churna or Pipali Kshirapaka. But care to be taken that whenever you advise Pipali Kshirapaka, wherever there is Pitta, Prakriti individual, so you have to be extra cautious, because it may lead to certain GI irritation, or sometimes even, intermenstrual bleeding in patients also. So whenever you advise, care to be taken whether the patient can take this prescription or not. And you also have ashwagandha, which can be prescribed in the churna form, or any other, not of course in a leha form, but churna would be an ideal way of advising to such patient, because plenty of studies proves that ashwagandha basically stimulates the functioning of the thyroid follicular cells, lowers the cortisol hormones also, which can basically reduce the function of the thyroid gland. So advising ashwagandha is a good way of managing the hypothyroid cases. Of course, with all of this, because diet and lifestyle plays a very important role in managing, because it's a metabolic disorder. So diet and lifestyle management plays a very important role in, hyperfunctioning of the thyroid hormones. So something which basically stimulates the thyroid gland to be advised to such patients. So you can either go for iodine-rich foods wherever there is iodine deficiency. So certain foods like seafoods, dairy products, or added salt can be given to the patient. You have zinc and selenium-rich foods, because zinc and selenium are basically involved into, so there is a remote involvement for functioning of these micro minerals. They basically are involved into synthesis of the T3 and T4, conversion of the T4 into T3, and the active form of these hormones. The metabolism as such of these hormones will be increased by these selenium and the zinc. Hence, foods which are rich in these also are good and can be advised in sufficient quantity to the patient. And the goitrogenic foods to be restricted, especially the cruciferous vegetables like broccoli and cauliflower. They're going to interfere with the normal functioning of the or the metabolism of the T3 and T4. Hence, these vegetables to be cut down, or even when given, boiled form of these vegetables to be advised to the patient. And the next comes the exercise. They play a very crucial role, because they're going to increase the metabolism in the patient. So symptomatically, you can try to manage effectively in the patients by advising, the exercises. So as well as you can go ahead with the certain yogic posture also to the patient. Now moving on to how effectively or rather clinically how to approach these cases. So imagine a patient walks in into your OPD coming up with the thyroid complaints. How are you going to manage? So you can basically classify these hypothyroid cases or understand these hypothyroid cases into a patient who walks in into OPD, either a controlled patient of hypothyroidism who just gives you a history that they're suffering from a hypothyroid case, effectively being managed with the hormonal replacement therapies. But a patient walks in into your OPD and says that, look, I want to try with the Ayurvedic medication. I do not want to take up any hormonal tablets for lifelong. And they seek your help, medical expertise. So in such case, first educate the patient that either there is no absolute requirement for them to shift to the Ayurvedic medication. So if only they can just continue with the hormone replacement therapy if there is no absolute symptom produced from that. Only if the patient insists on shifting, then you can taper off, advise the prognosis to the patient, taper off the medications, what hormonal replacement therapy, what the patient is giving, and then instead advise our medications. Don't abruptly stop any medications because patient may be taking these medicines at for a very long period of time and in a very large dosage. So dosage as such. So hence it is very crucial for you to taper in smaller dosages and then advise Ayurvedic medications to such patient. So then you have uncontrolled patients who walks in into OPD with the hormonal replacement therapy. Then of course continue the hormonal replacement therapy temporarily at the same dosage, and as an adjuvant give Ayurvedic medications to get the thyroid hormone levels to the control. Once they are absolutely under control, then later on you can try to taper off the hormone, whatever dosage the patient is taking. The next set of patient would be patients who comes up with controlled on hormone replacement therapy, but despite that, the lab values shows that it is normal, but patient have persisting symptoms associated with that. That there is lower metabolic rate symptoms seen in the patient. Then go ahead with the symptomatic management. Probably patient might have come up with constipation as an issue, digestive issues as an issue, or myalgia as an issue. So effectively try to manage those symptoms in the patient without altering the hormonal replacement therapy if the patient doesn't ask for any change. Next set of therapy, next set of patients are those patients who come up with either fresh case or they might be diagnosed earlier with the hypothyroidism, but they are not taking any medications from any other system. So they are basically uncontrolled case of the hypothyroidism cases. Then in such cases, you can directly start up completely with an Ayurvedic protocol. Only care to be taken that if the patient is pregnant, then kindly refer such patient to the contemporary medicine. As I've told you, now two lives are at risk because I have told you the unborn child later on may develop the developmental issues. So it is very crucial for you to refer such cases. And as mentioned earlier, if the patient has post-thyroidectomy cases or radiation cases, kindly refer because there the secretory cells itself are absent. So you cannot do much. Your role as an Ayurvedic physician is very limited here. But you can surely advise some symptomatic management to the patient because patient may have certain metabolism related issues. So you can surely advise certain symptomatic management in such patient as such. So let me just tell you a few clinical cases what we have effectively treated in our OPDs and how it has been managed successfully. So here is a case of male patient around a 28-year-old. So who came up to our OPD with fluctuating thyroid profile. So he was earlier diagnosed with hypothyroidism with 7 years history, and though initially he was not under any medications, later on. He had started already with the allopathic medications. So that is tablet eltroxin 75 mcg. Despite that, the thyroid levels was not under control. The TSH values was 10.24, you can see. And patient had other metabolism related, the gut metabolism related symptoms like sore burps or unsatisfied bowel. So patient when was subjected with anti-TPO test, the values were raised. So weight was in moderation considering his height. So, but the values and there was symptomatic presentation in the patient with the TSH not being kept under control. Now here you can see in such patient, so we have just basically begin with the Kanchana Ragugulu, along with Chitrakadivati. Note that goiter presentation was not seen in this patient. So despite that, you have to do, of course, here the lower metabolism symptoms are noticed. So Kanchanara Gugulu is given, Chitrakadivati, since the Agni Dushti features are seen. So along with Purnanavadi Kashaya. So why Purnanava is chosen over Varunadi Kashaya here is, as I've told you, Purnanava not just acts on acts as Dipana Pachana, here rather than Medo Dushti, the weight is normal. Here primary complaint is more of Rasa Dushti related features. So that is why Purnanavadi Kashaya was preferred rather than that of Varunadi Kashaya to the patient in the dosage of 15 ml BD before food. So once this was given, so in the next subsequent visit, we have seen that the patient complaint of sore burps had reduced. So because Pachana, Chitrakadivati primarily does the Pachana functions, and that is why the sore burps complaint has reduced. So, but patient still had lower appetite as a complaint. So, and TSH values, if you see, had substantially being reduced from 10 to 6. So we had continued. So the next visit, we continued with the Kanchanari Gugulu and the Punanavadi Kashaya, but the Chitrakadivati was replaced with Agni Tundivati. So more so specifically for Deepanartha, Agni Deepana purpose. So when 1 TID dosage, it was advised to the patient. So in the subsequent visit, we can see that the digestive complaints had completely resolved and the TSH values had come back to normalcy. So both in the next subsequent visit, we can see so that after 2 sittings, patient later on complained had on his own basically stopped all the medications. That is, after a brief period, patient had stopped the medications. By next year, almost around 6 months later, patient came to our OPD because once again the complaints had reoccurred. Though he was minded, the patient was still continuing with the allopathic medication in the same dosage, that is 75 mcg of L-troxin. Despite that, the patient had the symptoms had reoccurred in the form of lethargy, body ache, and unsatisfied bowel. And this time the TSH had elevated to 16.8 micro international units per milliliter. So what we had to do was once again restart the medication in the form of Kanchanara Gugulu, Chitrakadivati. Since you can see that patients more had lethargy related symptoms. So Varunadi Kashaya was preferred over Purnanadi Kashaya over here in the same dosage, that is 15 ml BD before, rather after food to the patient, was given to the patient in this visit. So in once again, even though this was advised, patient was not very keen on taking these medications. For a brief period, once again, he had not taken. So when the patient came back this time, the TSH was increased to 48.9. There was a brief gap of a few months before he came back to us. So when he had discontinued, you can see that the TSH increased to 48.92, and patient still complained of reduced enthusiasm, body ache, fatigue, and reduced appetite. So something to basically improve the Agni was required at a stronger level for us to tackle with the thyroid issues. So patient was advised with Kumari Asava this time, along with Kanchanara Gugulu. And since it's an Hashimoto's thyroiditis case, so we needed something for doing as a rasayana as well as tackling the autoimmune concept as such. So that is why Ashwagandha was advised to the patient along with Kanchanara Gugula and Kumari Asava. So when this was advised in the subsequent visit, we could see that the few of the complaints, especially the digestive complaints, had come down because Kumari Asava had effectively delivered its action over there, but lethargy and increased sleep still persisted. So, but the TSH values you can see effectively had reduced, come down from 48 to the 8. So this is a clear-cut sign that the medications were effectively being delivered to the patient. Hence, the same medications were continued this time to the patient. On the subsequent visit, we could see that the TSH values are further reduced to 5.7, and all the symptoms, whatever the patient had, basically effectively come down. So even till date, the patient is still continuing with the same set of oral medications. Now, moving on to the one more case where this patient is absolutely a fresh case. So, a female patient of 40-year-old complaining of hair fall, multiple joint pain, and lethargy since 1.5 years. Of course, the patient was diagnosed with hypothyroidism since 12 years, but patient was not taking any hormone replacement therapy here. So patient was taking for a brief period homeopathy medications, which too the patient had discontinued on her own since the last 6 months when the patient approached to her OPD. So you can see that the weight is normal over here when looking into the height. So the weight is just 56 kgs, but patient had myalgia and lethargy as a complaint while approaching to our OPD. So when the lab investigations were done, we could see that the ESR was slightly raised. CRP showed that it was, CRP and ESR values were increased, and RA factor was negative, though because the patient complained of arthralgia and myalgia, these tests were done. Only the CRP was raised, and TSH showed that it was 7.18. Of course, it's a subclinical hypothyroid case. So until 10, if the patient does not have much of a symptom, you can still wait and watch, correcting the diet and advising proper exercises to the patient. But since the patient had symptoms here, even though it's a subclinical case, we had to advise medications to the patient. So Kanchana Gugulu was advised, as it Gugulu content is going to reduce the the arthralgia and myalgia in the patient. Along with that, for the Agni Dipana Pachanatha purpose, Chitrakari Vati is advised, and Punanavadi Kashaya. So why Punanavadi? Once again, because Punanavadi Kashaya has anti-inflammatory effect along with doing the Pinapachana purpose. Hence, this was chosen to the patient considering the complaint in the patient. So we can see that in the next visit, when the patient approached us in the very next month, the joint pain had come down substantially, and lethargy also had come down. So TSH has come back to complete normalcy, that is 4.92. And in the subsequent visit, unfortunately, the TSH once again shot back to 7.57. So hair fall complaint still persisted, but joint pain, myalgia, arthralgia had absolutely reduced. So this time, so since for doing furthermore Deepana Pachana purpose, once again, going ahead with the, instead of the Chitrakadivati, Kumaryasa was advised to the patient. So because hair fall is also there, correcting Agni would be very important. Only when Rasa is corrected, you can expect all these hair fall and such complaints are going to come down. So Kumaryasa was added. Along with that, Purnanamati was Mandura was advised to the patient. Once again, we know it is advised for Pandu cases. So the complaints of hair fall would be effectively managed when we advise these complaints. So Purnanamati Mandura in 1 BD dosage was advised along with Kumaryasava. So now Mandura acts as iron supplement. Along with that, Punanava is going to deliver the anti-inflammatory and all of these purposes, and Kapha Medohara action also would be achieved when you advise Punanava in the form of Mandura preparation. So in the subsequent visit, you can see that the TSH has come down to 6.05. But since Mandura preparation was given, probably though we have few of Anulomaka drugs in these preparations, despite that patient complained of constipation as a complaint. So we all know the iron supplements are known with constipation issues. So known to cause the constipation issues in the patient. So what we had to do was the stop the Punanavadi Mandura and continue with, along with Kumaryasva and Kanchana, go ahead with the Trifala Chuna as it does Anulomana, Kapha, Medohara also function. So with that, we could see that this in subsequent visit, the TSH absolutely come back to normalcy. No complaints of hair fall or constipation issues seen in the patient. So in the subsequent visits, what the patient has come up. So even the Trifala Churna was stopped on because patient did not have any Vibandha complaint. So only Kanchana Gugul and Kumaryasava was continued. Until date, patient visits to our OPD with the same set of oral medications being continued and the TSH values being maintained at a normal rate. Next, moving on to one more case, a female patient with around 40 years of age. Here, slightly the complaints are different. So here the patient comes up with irregular menstrual cycle. So wherein the patient has once in 45 days, the patient gets cycle, fatigue, chest burn, myalgia being the presentation. Patient already was taking allopathic medication at a very large dose. 150 mcg of thyroid tablets was taken by the patient. So patient was being diagnosed since taking these medications since 8 years. patient here clearly came up with saying that despite me taking this complaint, I have all these issues. So kindly, I want to switch on to Ayurvedic medication. So kindly prescribe me those. So when we look into the weight, so patient had 76 kgs of weight. So considering to the height, slightly the BMI was increased. And so what we did was initially we explained the prognosis to the patient, told her about the concept of gradual tapering, and we are not going to stop of such a large dose of the Tyrannom at once. So in the initial phase, so I've advised her with Kanchanara Gugulu, Chitrakadi Vatti, and Ashwagandha capsule with the same principles of what I had advised earlier. And Varunadi Kashaya was preferred because Medo Dushti is more predominant here. Weight, you can see that is been at a higher side. So Varunadi Kashaya was preferred to such this patient. So immediately by the next visit, when after 2 months, when the patient visited to OPD, so the TSH had come back to the normal values. And so this was the time when, so we made an attempt to reduce the Tyrannom dosage to 125 mcg. So symptomatically, patient was completely feeling better. So she was ready to continue with the medications. So in subsequent visits, the TSH values were getting maintained at a normal rate with no absolute symptomatic presentation. So we further reduced the the Tyrannom dosage to 100 mcg this time. And once again, we could see that post reduction also, the TSH values being effectively maintained till the end of the till the March of the that year. And in the next visits, we could see that since the TSH values were maintained, further down the Tyrannom dosage was reduced to 75 mcg. So clearly you can see that the patient did not have any symptoms, and even the TSH values were getting maintained with the same dosage. So that is when the attempt was made to further reduce from the 100 mcg to 75 mcg. And once again, we could see that the values being maintained despite the reduction in the Tyrannom dosage. So almost by the end of that year, we could see that unfortunately the TSH value suddenly shot up to 8 micrograms. So all we had to do was slightly alter the dosage. So the patient was this time advised with the Kanchanara Gugulu 2 BD, Chitrakadivati 1 BD, and Punanavadi Kashaya was given to this patient. So because patient was complaining of a bit of fluid retention in the body. So next, in the next subsequent visit, we could see that the TSH value had come down to 6.16, and thereby in next visit, we could see that the TSH had come down to 2.24. So at this time, we made an attempt to further reduce the Tyrannom from 75 to 50 mcg, and even Ayurvedic medication dosage, what was advised from Kanchanara Gugulu 2 BD, was slightly reduced to 1 TID, and continuing with the Chitrakadivati and the Punanavadi Kashaya. So in the subsequent visits, we could see that the thyroid value being maintained at 6.69. So because there was a reduction in the hormone levels, supplement what was given to the patient. So the Kanchanara Gugulu was still continued at the same dosage with Punanavadi Kashaya and Chitrakadivati. And in the next few sittings, we could see that the values were gradually reducing to the normalcy. Once the TSH values came to 5, then we have further reduced the Kanchanara Gugulu to 1 BD. And further down, the patients had a bit of bloating related issues. So instead of Punanavadi Kashaya, Kumariyasa was advised because it does Deepana and Pachana. And instead of the Chitrakadivati and Punanavadi Kashaya, Kumariyasa along with Trifala Churna was advised. Trifala Churna here does the Anulomana, and Kumariyasa does the Deepana Pachana for us, along with Kanchanara Gugulu 1 BD. So this effectively reduced the bloating complaints in the patient, and we could see that in the next subsequent visits, the thyroid values being effectively managed. This patient too visits to our OPD till date, and the thyroid values are still maintained. TSH values are still being maintained at a normal rate, and the right now, I think even the Tyrannom dosage is also being continued at 50 mcg itself. So looking into probably in further sittings, we'll have to plan on to further reduction. So it is always a gradual reduction in the past 2 to 3 years what we have achieved by reducing such a large dose of the Tyrannom dosage what the patient was taking. Now, next is a very interesting case of a metabolic syndrome being quoted here. A female patient of just very young age, young female patient of 17 years. So who came irregular menstrual cycle, 70 days, and very minimal bleeding since last 1 year. There was weight gain issues, mood swing, and hair fall related complaints. What she came up, basically, she had initially visited the Prasuti department as, and later the case was shifted to the once the later on the patient was basically shifted to the Kayachikitsa OPD. So patient was basically diagnosed with PCOD changes in the USG, and with 4 years history of hypothyroidism, patient was already taking 50 mcg of Tyrone, despite that the previously mentioned complaints were her height, the weight was on the higher side, and the BP when recorded was showing 140 by 80 mm of Hg. Considering her age, it was slightly on a higher side. So patient was initially advised with Kanchanara Gugulu, Chitrakari Vati, and Varunari Kashaya because Medo Dushti is more predominant here. So PCOD changes are seen, weight is increased. Varunari Kashaya was preferred over here. So on in initial setting itself, we could see that the TSH was absolutely under very well under control. That is 1.77. So directly with the first visit, the dosage was reduced to 37.5 mcg. So very smaller dosage was reduced. We did not come up to the 25 mcg. So the intermediate dosage of 37.5 mcg was advised to the patient. So in the subsequent visit, we could see that the TSH values were maintained at a normal value. BP, we could see that the slight fluctuation, 130 by 90. Patient was advised with a salt-free diet. Patient was told to manage with the exercises. Triglyceride level, you can see it is 190 mg per dl. So we can see that the presentation of fluctuation in the BP, even the lipid levels being altered, thyroid levels being monitored. So clearly the patient is heading towards the metabolic syndrome. So in the next subsequent visit, you can see the weight, being slightly on the higher side itself, being increased. So TSH well under control despite the reduction. BP slightly, you can see that the diastolic is on a higher side. Still, we took up a leap because the TSH was very well maintained. So dose was reduced to 25 mcg. So on the subsequent visits, though the TSH values were getting maintained, we could see that there was fluctuation in the BP. So ranging from 160 100 by mm to 140 by 100 mm of Ag. So for anulomanartha purpose, so since there is BP fluctuation, we did not start off with any other medication. Looking into that, there is Vyanavata and the Pranavata Dushti, which would have basically been primary pathology, Kaphavrita, Udana, or Kaphavrita, Vyana, and Udana being affected. So the Trifala Churna was advised, which does Kaphahara as well as Vatanulomana. So that is why Trifala Churna was advised to this patient, 1 teaspoon at HS. There was no much of a difference, we could say, only the systolic pressure reduced on the subsequent visit. But since the TSH was getting maintained and weight was getting maintained at almost at the same level, so the dosage was reduced to 12.5 mcg from 25. In the next subsequent visit, we had asked the patient to record the BP at home too. So we could check that there was higher fluctuation in the blood pressure. Triglyceride values had substantially increased to 295 this time. So we could not take up much of a chance at this juncture. So we had to advise a drug, patent medication was advised, which had Sarpagandha content for a very brief period, continuing with the rest of the other medication of Kanchanara Gugulu, Chitrakadivati, and Varunadi Kashaya. So once we did that, and this time the thyroid was completely stopped because TSH all this while was getting maintained at a very good level. So in the next visit, we could see that the BP had come down after adding the Sarpagandha content drug, and the TSH was getting maintained, and that is why since the patient agreed to get admitted at this juncture, patient was admitted, and Arona Matra Snehapana was done with the Varunadigrita, followed by Virechana was advised. Now, why Virechana was chosen here instead of Pamana is primarily because even BP fluctuation is seen. So here, considering that it is almost Raktavrita, Raktagata Vata, Rakta being the Ashraya over there. So where the Dosha Dushti has taken place, so we have chosen Virechana as a preference over Vamana, and Virechana was given to this patient. So throughout while we have monitored the blood pressure, and it was effectively getting monitored, maintained. Hence, no medications were advised for managing the blood pressure. So during discharge, hence only Kanchana Gugulu, Chitrakadivati, and Varanadi Kashaya was advised to this patient. So in the next subsequent visit, we could see that the triglyceride values had slightly reduced to 240 mg per dl, ASH very well maintained, BP very well maintained after Virechana. So continuing with the same medications, we have advised proper diet and exercise to the patient. Since the patient was quite young, probably managing the diet and the exercises was very difficult for her. So despite that, on proper repeated assurance to her and asking her to continue with the same, we could see that all the parameters getting maintained in the next consecutive visits. So the triglyceride gradually reduced to 190 and BP 110 by 80 mm. And slightly there was fluctuation in the vitamin D values in the patient. So vitamin D supplements were given. So this also invariably helps in managing the thyroid, sorry, not thyroid, the lipid values. So vitamin D supplements were advised along with that of advising our Ayurvedic medications to this patient. In the next visits, we can see the BP being maintained and the triglycerides specifically had come down to 114 mg per day, which is an absolutely normal reading. PSH once again being maintained. Hence, same set of medications are continued till date to the patient. Patient visits to our OPD every 2 months or once in 3 months, continuing with the same set of medications. And till date, the BP, TSH values as well as the triglyceride values are very well maintained in the patient with the same dosage. And we have stopped all the hormonal tablets to the patient, just effectively continuing with the Ayurvedic medications as such. So with this, I think I have shown you a few cases of how effectively we have managed both undiagnosed or rather the fresh cases and the treated cases of the thyroid disorders. Now let us just move on to the hyperthyroidism. So we all know what exactly is hyperthyroidism. I have told you earlier too, wherein there is hyperfunctioning of the thyroid gland. There is excessive production of the T3 and T4. Thereby, there is accelerated metabolism or increased metabolism, what we see. So earlier, if you see, the incidence of these hyperthyroid cases were very less when compared to that of hypothyroidism. But recently, we can see that there is a surge in these cases as well. So global incidence, if you see, around 1 to 2% of the population worldwide are affected. Primarily, once again, it's a women who are affected with young age, ranging from 20 to 40 years, who are basically affected with these hyperthyroid cases. And in India, we can see around 3 to 4% of Indian population getting affected with the hyperthyroidism. And specifically, once again, we can see that the areas where iodine deficiency is seen, there the hyperthyroid cases are more. Now, you might wonder how that I have mentioned that iodine deficiency is leading to hyperthyroid. So the reason being simple, that is the feedback mechanism. So initially, whenever there is very less amount of iodine being seen circulating in the body tries to compensate with the help of the feedback mechanism, and the precursors are produced at a larger amount, and the gland in itself is stimulated at a larger rate so that more amount of T3 and T4 is being produced. So thereby you can see that there is a surge in the T3 and T4 levels. Later on, when consistently the iodine has been reduced for a very large amount, of course the case will shift towards the hypothyroid case. So initially, if the patient has approached you, you can expect change, or rather the changes of hyperthyroidism seen in such patients. So in iodine deficiency cases too, you can see in the initial aspect the presentation of hyperthyroidism message. Now moving on to the causes. So primarily we have autoimmune cause, just like for the hypothyroidism. So hyperthyroidism primarily presents because of an autoimmune condition called as Graves' disease. Then you have the Plummer's disease, nothing but the toxic nodular goiter. That is, you have multiple nodules seen on the thyroid gland, which has more amount of secretory cells. Hence, there is more amount of thyroid hormone being produced. So, which leads to hyperthyroidism. Then you have thyroiditis, nothing but the inflammation of the thyroid gland occurring because of various other conditions. We'll deal with it later. So this can lead the thyroid hormones. So thereby the hyperthyroidism can present. Then there is a very rare case of ashwagandha. Also, you might find plenty of cases of ashwagandha cases being registered that ashwagandha intake at a larger quantity or unscientific intake of ashwagandha, especially the extracts of ashwagandha, can lead to the or rather hypothyroidism because of thyroiditis. So ashwagandha, we have told earlier, stimulates the thyroid gland. So when taken unscientifically without consultation from proper consultation from a physician can lead. So you have a history of patient complaining of thyroiditis or hyperthyroidism, giving you a history of self-medication of ashwagandha for a very long period of time, you have to suspect that also. So when you withdraw, ashwagandha in itself can reduce the thyroid levels as such. So then you have excessive iodine intake. We all know large quantity of iodine supplements being given can also lead to the since it's a substrate which is required for the thyroid hormone production, large quantity can stimulate overstimulation of thyroid gland can occur, and more amount of T3 and T4 can be produced. So that is why there is a drawback associated with the iodization of the salt. So there is some section of people who basically argue against iodization of the salt also. So, okay. Then we have secondary hyperthyroid cases, that is pituitary abnormalities, some large amount of TSH being produced because of certain hormone secreting you know, tumors, which can substantially later stimulate the thyroid gland to produce more set of T3 and T4. So this is a secondary cause. So here too, the role of, if you see the pituitary adenomas, our role as an Ayurvedic physician is very less, because we probably have to refer such cases. So surgical management may have to be required so as to reduce the amount of the TSH being produced, and thereby you can control such cases. But the rest of the other cases, so we as Ayurvedic physicians have a role to play, so which we'll be discussing at a later aspect when it comes to treatment. So pathogenesis, I've told you, whenever there is excessive production of hormones, since its effect is seen on metabolism, all the metabolisms are going to get increased, starting ranging from the gut metabolism to the cardiovascular changes, to that of the body temperature being maintained, or rather increase in the body temperature. And all of these you can see, even the lipid metabolism also will be increased. So fat accumulation is going to come down, and patient may experience weight loss as a complaint. So moving on to specifically the most important cause, that is the Graves' disease. So in Graves' disease, I've told you, primarily in a genetically susceptible, mind it, in a genetically susceptible case, so patient when gets exposed to some viral or a bacterial infection, so of course the body's immunity is going to try to act against these virus or bacteria. So when the accelerated immunity would be there, the immune is not just fighting against the virus or the bacteria, rather starts counteracting on the thyroid gland itself, then this condition occurs. Now, just because one suffers from any virus or a bacterial infection, they're not going to suffer from Graves' disease. Only in a genetically susceptible individual, this condition occurs. So it so happens that the whatever antibodies which are generated against the antigens which are there in the body, these antibodies basically are going to confuse the receptors which are basically present on the thyroid gland. So, we have specific receptors on the thyroid gland which senses whenever there is arrival of the TSH. So once they sense it, they allow the TSH to attach to themselves, and thereby the thyroid gland produces the T3 and T4. So, but in such patient, it so happens that these antibodies mimic like that of TSH. So the receptors get confused. So they are going to stimulate the thyroid gland to produce more amount of T3 and T4. So this is a autoimmune condition which is widely seen these days, or at least rather there is a surge in these cases currently. So primarily occurring in genetic susceptible individual. So the consequence would be that there is large amount of T3 and T4 being produced, and the autoimmune attack, whatever takes place on the thyroid gland, so there will be an inflammatory response taking place and overstimulation of these follicular cells, which leads to the goiter formation or inflammation taking place in the thyroid gland. So here too, goiter formation can occur. So goiter can basically occur both in hypothyroidism cases as well as hyperthyroidism cases. So one has to be extra cautious when you see a goiter as a presentation. So look into the hormonal values and then take a call on to what might be the diagnosis. So when it comes to symptoms, so you have since the basal metabolic rate is increased, all signs and symptoms pertaining to that you are going to notice. So will have unexplained weight loss. Then cardiac functions, cardiac activity is going to get increased, pumping activity. So patient may experience palpitation or tachycardia. Then patient's body temperature basically is going to increase over here. So sweating would be there as a consequence, and patient cannot expose themselves to very increased heated environments as such. Patient might have tremors as a complaint. Anxiety would be there as a mood change, and you can experience, the patient's appetite would be increased. So patient's metabolism is at a faster rate. Gut motility would be increased. So patient will have loose stools as a complaint. So because of which also patient's weight tends to fall down. And despite patient having larger food intake would be there, the weight is not going to increase. So along with that, there are very specific symptoms what you can see. There will be some inflammatory response what you see because of the autoimmune attack taking place in the ocular area, leading eyeballs will be seen as shown in the picture. And Graves' dermopathy also be there, wherein inflammation be seen on the skin also, leading into reddish inflamed skin. And the patient might have fatigue as a complaint, insomnia as a complaint, and even sexual functions also can get altered over here. Patient might have erectile dysfunction and reduced libido also. So when the patient's symptoms are not managed, severe set of complications can occur where hyperthermia would be seen, large, there'll be high fever noticed. So along with that, severe tachycardia, that is heart rate is going to increase. Along with that, patient might have even severe altered sensorium features also, like delirium and coma also. So it is very important. So the set of symptoms what you see, the complications what you see in hyperthyroid is more severe when compared to that of hypothyroid. So hence it is very, very important for us to detect or diagnose the case and then effectively treat such patient at the earliest. So when we move to the investigations, primarily if you see the TSH levels, if you see, they'll be on the lower side because of the feedback mechanism once again. T3, T4 are going to get maintained in the initial phases, but over a period of time, they are going to get elevated because of the failure of the mechanism. And then when you look into the specific test for the Graves' disease, you have to go ahead with once again the thyroid antibodies test. They are going to will be raised over here. So this test will both depict the Graves as well as the Hashimoto's disease, that there is some autoimmune attack going on the thyroid gland will be detected. So looking into the TSH and the T3, T4 levels and the symptoms, you have to diagnose whether it is a Graves' disease or it is an Hashimoto's thyroiditis case. Then we have, of course, imaging techniques, what you can do, ultrasound of the thyroid gland to rule out or rather detect what might be the cause, like you have nodular goiter presentation, or because of the Graves' disease, you'll be able to differentiate, or if there is any malignancies also, you can detect with the help of the thyroid scan, or rather the ultrasound scan. And then you have radioactive iodine uptake test. So with this, you'll be able to detect regarding any mass seen or any nodule seen. You have thyroid scan also. So thyroid scan is also a nuclear study which is done. Once again, with the ultrasound, you can basically detect the structural changes in the thyroid gland. And we like the thyroid scan, basically ultrasound scan is for the structural changes. Thyroid scan basically is for the functional changes. So looking into the underlying condition, whatever suspicion is there, you have to decide whether one has to be subjected for an ultrasound scan or just the thyroid scan. Now, thyroid scan is a nuclear study. So certain radioactive substance will be given. So functional abnormalities, if you suspect any malignancies and such conditions, you have to go for a thyroid scan instead of the ultrasound scan. Now, moving on to the complications. So, as I told you, arrhythmias are a common complaint. So atrial fibrillation is what you can see in such patient. Eventually, this can lead to congestive heart failure also as a long-term delayed complication in the patient. And since the thyroid hormones maintains the osteoclast and osteoblast levels, so osteoporosis is a long-term long-term complication what you see. So osteoclast function will be increased. So thereby there is bone degeneration and thereby osteoporosis occurs. And even the calcium also will be expelled at a larger rate in such patient. So that can also eventually lead to osteoporosis. And of course, you have something called as thyroid storm, which is a life-threatening condition, also called as thyrotoxicosis, where patient might enter into a stage of altered sensorium or coma also. So looking into the Ayurvedic view, just like earlier, the functioning of the gland is what we see in the form of functions of the Agni. So in hypofunctioning, you see that Agni functions are being reduced. And in hyperfunctioning, you can say that the Agni functions are basically elevated. So you can, one of the condition quoted under the classics in the form of Atyagni can be considered here. This is Charaka's reference where he says, so with the Atyagni, you'll see that there is Pitta and Kupita Maruta. That is, there is elevated Vata and Pitta, but Kshina Kapha. So that is what are the features, what you clinical features, what you see in the patient in the form of that there is Agni and Bala being reduced. And Pachatyagni Tekshna Dashu, that is, even if the food intake has been larger quantity, the food is getting digested at a very faster rate. So obviously the gut motility will be increased at this juncture. And you can see that after the Pachana of the Agni, it is going to do the Dhatu Pachana also. So Raktadi Dhatu Pachana. So that is why you will see that weight loss and such complaints you will experience in the patient. So and more so, he also goes ahead with explaining the symptoms like Shwasa, Daha. Daha in the form, why Daha? Because raised body temperature will be seen and heat intolerance is expected. Those features being explained over here. And then Murcha being told. So when uncontrolled hyperthyroidism is there, then patient may also enter into a stage of coma. So all of these features being depicted as a feature of Atyagni. Hence, you can, one of the condition what you can take would be in the form of Atyagni as a presentation. Second, of course, whenever there is any goiter as a presentation, even Galaganda explanation, what was told over the earlier slide while explaining the hypothyroidism can also be considered over here, because it's a structural change what you see, irrespective of the function what might be seen as an underlying. So holistically, if you see, you have to manage the Agni aspect, control the, or rather maintain the Agni, not reduce it, maintain the Agni, and then rather tackle the Vata and Kapha also, because Galaganda would be a presentation over there. So maintain or reduce or maintain the Vata and Pitta, at the same time reduce the Kapha. So all of this to be done at a similar. So managing the hyperthyroid case is a bit of a tricky scenario. So and the complications are also very severe. So one has to be extra cautious. So Vata Pitta Shamana to be done. You have to give something which is Balya and Brahmana, and as well as go ahead with the Rasayana also. Next, looking into the management principle, as I've told you, you can go ahead with Shodhana modalities. So in Bahdoshavastha, so one has to be extra cautious when you advise any of the Shodhana modalities, because already there is weight loss, already patient complains of loose stools. So in patients who do not complain of loose stools, you can go ahead with Snigdha Virechana, Snigdha Mrudu Virechana, because it does Vata Pitta Shamana. Snigdhata would be there, maintains the Vata. Don't go for a Ruksha Virechana over here. So you can go ahead with either Gandharvasthadi Taila or Nimamritadi Eranda Taila can be advised to the patient. Then you can go ahead with Basti Chikitsa also, primarily Madhu Tailika Bastis or Yapana Bastis or Raja, especially the Rajapana Bastis can be advised to the patient. Then one can also go ahead with Nasya, especially the Kanchanara Swarasa Nasya can be advised to the patient. Plenty of studies are there which proves that Kanchanara Swarasa Nasya has been effective in managing these cases. Shirodhara can be done as patient is going to come up with a bit of mood related changes, anxiety and such conditions. So Shirodhara can be advised with Himasagra Taila, Kshitrabala Taila or Brahmi Taila can be advised to the patient. So based on the underlying symptoms, one has to take a call onto what therapeutic modalities can be advised to such patient. Moving ahead with the Shamana, so Atyagni Chikitsa can be applied here. So you can go ahead with Sushikara Rasa, Kamaduga Rasa, Pravala Panchamrita Rasa, all does the Pitta Shamana over there. And since goiter presentation, Galaganda presentation is also there, you can go ahead with the Kanchanara Gugulu and Chandra Prabhavati. Interestingly, it is Tridosha Shamaka, Rasayana. So good effective in treating the Galaganda also. So Chandra Prabhavati can be advised to the patient. Then Saraswatarishta, so to tackle the arrhythmia related changes, to tackle the anxiety related issues, you can advise Saraswatarishta to the patient. Then you have Draksharishta as which can be advised to patient. So more so specifically because it maintains the Agni, at the same time does Vata Pitta Shamana, Balya, Brahmana. So Draksharishta can be given. Then you have Ashwagandha Rasayana, which can be given. See, surprisingly, we have told that Ashwagandha is a Nidana, but Ashwagandha Rasayana does Balya Brahmana. Ashwagandha as such is Tridosha Shamaka. So, in specific quantity, looking into the signs and symptoms, you can surely go ahead with Ashwagandha Rasayana also. You can go ahead with Shatavari Grita or and Shatavari Guda also, because it does Vata Shamana, Pitta Shamana, along with that Balya Brahmana. So, very effective in managing the hyperthyroid cases. So these are a set of Shamana Aushadhis what you can advise in managing the hyperthyroid cases. Now, practically, once again, let us look into how in an OPD setup you can manage these cases. So once the patient walks into our OPD, look into what is the cause. So as I've told, if you have cases where secondary presentation are there, kindly refer such cases. If it is a primary case, look into what is the cause. So if a patient is having, the controlled, a patient walks in with the controlled levels of the hyperthyroid, already diagnosed case comes up with the controlled values, already taking anti-thyroid hormones, anti-thyroid tablets, but patient has a bit of symptoms or insists saying that they want to switch on to Ayurvedic medications because there are certain complications associated with these anti-thyroid tablets. You cannot advise it for a very long period of time. So there is a toxicity associated with that. So since patient might be aware of those and insists on shifting into Ayurvedic medications, then once again, explain the prognosis to the patient. Look into whether patient is looking for any fertility related issues as such, because if patient is planning for a family, then advise them not to shift to an Ayurvedic medications because any irregularities can lead to infertility issues. So advise the patient to temporarily continue with the same medications and later on probably shift to Ayurvedic medications once these issues have been sorted out. As if fertility is not the concern, then you can surely advise Ayurvedic medication to the patient and kindly taper the medications. Do not abruptly stop the medication. Taper the medications of whatever the patient has been taking for the hyperthyroidism. Next, second set of patient would be the uncontrolled or freshly diagnosed case of the hyperthyroid. So you can directly start up with the Ayurvedic medication. Once again, explain the prognosis because in rare cases, as I told you, if the patients present with arrhythmia and such complaints, if you're unable to manage, you may have to shift the patient to the allopathic or contemporary medication. So explain the prognosis, take the patient's consent, and then go ahead with the Ayurvedic medications. So let me show you a few cases wherein I have effectively treated with the hyperthyroidism with the Ayurvedic medications. So here is a male patient of 42 years coming up with complaints of, the loose stools, weight loss, fatigue, palpitation, and tremors. Mind you, these complaints were present not when approaching the OPD, but these complaints were present 3.5 years back. So patient had already started with the anti-thyroid tablet, that is Methmes, in the dosage of 15 mg BD, and Inderol. So Inderol is a anti-arrhythmic drug to control the the arrhythmias or tachycardia. So 10 mg OD is advised to the patient. Patient was already taking it. Since patient knew the toxicity of the medications, patient wanted to switch to Ayurvedic medications. So on examination, no goiter was seen. Weight was being managed at a right way. So patient was explained all the prognosis after taking into the consent of the patient. Then patient was advised with the Ayurvedic medication and gradual tapering was done here. So in the initial setting, patient was advised with Kamadugarasa in 1 BD dosage. Draksharishta was given in 15 ml BD dosage, along with Ashwagandha Leha was advised. So as I told you, primary principle being the Vata Pitta Shamana, Deepana, Agni being maintained, and along with that, Valya Brahmana function being achieved. So once we did that, the patient was comfortable with the medications. Once we realized that, in the next sitting, we gradually reduced the dosage of the anti-thyroid tablet. That is, Methmes was reduced to 10 mg BD. Note it down. the Inderol tablet or the antiarrhythmic drug was continued. So we do not want to, advise any tapering of that tablet dosage. One, because there is no much of complication associated with that. Second, there might be an instance when suddenly the palpitation and such complaint might immediately start up with. So that is why the same tablet dosage was maintained. Only the meth-miss tablet was gradually reduced from 15 mg BD to 10 mg BD. So in the subsequent visits, when we tried to note down with the TSH values, it was getting maintained. It was not getting reduced. So same thing was continued. And after another 2 months, the tablet dosage was further reduced from the Methamis 10 mg BD to 10 mg in the morning and 5 mg in the night. So tablet Inderol was continued at the same dosage. So weight was getting maintained. And in fact, because after starting the Ashwagandha Leha, the weight was increasing. And we could see that all the vitals were getting maintained. Patient did not have any symptoms. So we were continuing with the same, medication, Ayurvedic medications for the subsequent visit also. Later on, in the next visit, the TSH, looking into that, the TSH was getting maintained and not in the lower side. So the dosage was further reduced from tablet Metmes 5 mg, which was the patient was taking at bedtime, was stopped completely, with only 10 mg OD being maintained. So an Inderol tablet was continued at that same dosage. So with the subsequent visits, we could see that all the vitals were getting maintained, weight being maintained, TSH also with the same values, and orally Ayurvedic medication, same set of medications were continued. No changes were made. And over the few next visits, we could further reduce the Metmes tablet to 5 mg OD. So with 5 mg OD, all the vitals were getting maintained, and further reduction was not done. Same tablet dosage is being maintained along with the Inderol tablet. So this is how we have effectively reduced the tablet dosage. In future visits, if the patient doesn't complain of any other symptoms, we can further continue with reducing the oral medication, whatever the patient or the anti-thyroid tablet, what the patient has been taking. So next is one more, case of female patient, 18-year-old, complaining of irregular menstrual cycle. Once again, visiting to our gynec OPD. So where patient had repeated cycles. So and every 15 to 20 days, she complained of having a cycle. And the patient, once the diagnosis was made as hyperthyroid, the case was shifted to the Kaya Chikitsa OPD. So patient had on examination, so patient on repeated questioning, patient complained of slight tremors, occasional sweating with slight palpitation occasionally. So once again, patient was explained with the prognosis. After the consent, the medications were began with Suchekarasa. Chandraprabhavati was advised to the patient, and along with Draksharishta was given along with Ashwagandha Leha. So here we could see that the patient had a bit of diffuse goiter as a presentation. That is why Chandraprabhavati was also added. So once this was done, you can see that the TSH values, which was in 0.01 levels, in the next subsequent visit, there was further, reduction, that is 0.08. So we could not get much of a result, but weight was getting maintained. So we had replaced the, the Suchikarasa to that of Kamadugarasa, and rest of the other prescriptions were further getting being continued. So we just wanted further Pitta Shamana being done to the patient. So on the subsequent visits, we could see that the menstrual cycle, which the patient was having, frequently, that came to normalcy. Okay, and the tremors, basically, and sweating, which was there occasionally, was further being continued. But oral medications were still continued in the same way, because the TSH was gradually coming up from TSH 0.08 to 0.05 value. So we are continuing the same medications. On subsequent visits, we could see that the TSH was gradually increasing, and it had come back to 0.4, which is a normal value. So, in the next visits, since there was no, complaints as such, so the same set of medications were continued to the patient. Weight was being maintained, vitals were normal, and we can see the shooting up of the TSH. So back to complete normalcy, that is 1.02. So this is how, without adding any antiarrhythmic drug, we could manage a case of hyperthyroidism. So next, moving on to, let me just tell you what if the structural abnormality is there. So all these cases, what we have told is a functional abnormality. So in structural abnormality, let me just give you a brief idea. So goiter as a presentation when the patient approaches the OPD. So get into the details, go for USG and if required, and then looking into the thyroid reports, the TSH and TD actual diagnosis. So if the patient gets diagnosed with the simple diffuse goiter, wherein the thyroid gland in itself is basically enlarged. So no treatment is required. It's a benign presentation. A T3, T4, TSH will be normal in this instance. They are basically not having any secretory cells, hence not producing any hormones. So don't advise any treatment. Just explain regarding the prognosis to the patient, and you can just observe the patient. Most of the time, they do not turn out into any malignancy. You can just wait and watch. Next case is a case of simple multinodular presentation. So USG will suggest that there is multinodules. There is plenty of nodules seen on the thyroid gland. So they'll be, if you look into the hormonal values, here too T3, T4, TSH will be absolutely normal. So in such instance, just look into whether the nodules are small in size or large in size. If the size is small in size, just you can advise certain Medohara, Kafahara medications so as to ensure that they don't grow in size. So you can go ahead with Kanchanara Gugulu, Shivagulika, Varunadi Kashaya can be advised to the patient. Keep monitoring and check for the size. So once in a while, if there is any growth, if it turns out into a larger size, then there are complications because they can put up a pressure on the surrounding structures. So especially the mediastinal structures, mediastinal compression can occur. It can put up a pressure on the larynx leading into dysphonia. It can put up a pressure on the esophagus leading into dysphagia as a presentation. So exactly depending upon the site where exactly the growth is present, if it becomes larger in size, complications are bound to happen. So if it is small, advise oral medication, explain the prognosis to the patient, and observe close monitoring to be done. In case if it is a large one, kindly refer such patient to surgical department because that is where partial thyroidectomy need to be done. Only then you can expect the complication to reduce. Otherwise, just advising oral medication is of no use in such case. It's purely a surgical case. So that is where you have to differentiate and decide where or set up a boundary of what cases you can treat. Next, moving on to if you have a case of acute thyroiditis. Goiter presentation will be there, and patient may give you a history of bacterial upper respiratory infection. Okay, patient will have painful swelling in the throat, and when you do the thyroid profile, T3, T4, TSH will be normal, but you can see in the CBC there will be fluctuation, that there will be leukocytosis, that is WBC counts are increased. Then in such case, so you may have to advise antibiotics. So once again, this case is primarily may have to be referred to the contemporary medication. So if the patient does not have an acute thyroiditis, rather suffers from subacute presentation, that is because most of the time a viral infection would be in history here, not a bacterial. So there is no role of any antibiotics. So patient once again has similar presentation. There will be painful goiter presentation. But here you can see that you can expect most of the time that the T3 and T4 will be slightly raised. So, but it is a temporary increase in their T3 and T4. So, in such cases, generally, as per the contemporary medicine, generally NSAIDs are advised, steroids are advised so that the inflammation comes down. Because once again, anatomy and pathology which occurs over there. So, if required, anti-thyroid tablets are advised as per the allopathic medicine. But such cases, instead of going ahead with these, you can effectively try to manage it with the Ayurvedic medications. So, you can go ahead with Atyagni Chikitsa as advised earlier. You can go ahead with Trifala Gugulu, Gandhaka Rasayana, which can be advised to the patient to treat the subacute thyroiditis. So this can effectively manage the subacute thyroiditis rather than going ahead with the steroid presentation, steroidal medications or the anti-thyroid drugs. But when you have acute thyroiditis, so role of Ayurveda becomes limited. You may have to refer the patient to the contemporary medications. What if the patient comes up with the chronic thyroiditis? So generally chronic thyroiditis is wherein you can find that the T3 and T4 levels will be normal, TSH will be raised. most commonly seen in Hashimoto's thyroiditis. So in such case, you have to go ahead with the, as mentioned earlier, Rasadushti Chikitsa has to be done. So Vata Kapahara Chikitsa and Agni Chikitsa, Agni Dushti Chikitsa has to be given. With this, you can manage the chronic thyroiditis. So whenever structural changes are seen, determine what might be the underlying cause and then take a call on to what would be the presentation. So with this, I would like to conclude saying that overall, whenever you have any case of thyroid, so determine the cause first. If there is any specific cause like an autoimmune history, the autoimmune being seen as a presentation, then the fluctuations might be very faster. So you have to advise the prognosis to the patient, explain the prognosis well in advance to the patient. Drug history is there, you may have to withdraw it. Okay, and determine what exactly is the presentation, whether there is hypo production or hyper production based on looking into the TSH values. You'll be able to determine that, then determine the line of management. Next, to find out what exactly, or rather further differentiate the cause, you can go ahead with the diagnostic procedures, what we have to do, like scans and the thyroid profile. And later on, deciding whether it is a hypo or a hyper, take a call. If it is a hypo, go ahead with the Rasadushti Chikitsa, Agni Dushti Chikitsa. Hyper, Atyagni Chikitsa has to be done. And if goiter structural changes are there, then Galaganda Chikitsa may have to be advised onto the patient. Then for preventive aspect, of course, diet and lifestyle plays a very important role, because these are metabolic changes what you see in the body. That is why correcting the metabolism, you need lifestyle and exercise, which has to be effectively followed by the patient. So finally, I can say that Agni is a crucial thing which has to be managed. So first correct the Agni, may it be hypo or hyper. Ensure that the Agni function has been managed, and not all cases can be treated with Ayurveda. Know your limitation, determine what you can treat, and then treat the case. So with this, I would like to conclude my session. Sorry. Sorry, sorry for the interruption.
Thank you so much for very informative session on the hypothesis. So now, either question and answer. So I call Dr. Gayatri ma'am to continue with the question and answer session.
So the session is open for discussion. If you have any doubts, kindly ping in the message box, or you can hear who are offline, and they can write on a sheet and pass it over here. Ma'am, shall we start, ma'am?
Yeah, sure. Go ahead.
Ma'am, shall we start?
Yeah, go ahead with the questions.
So there is a question from our final year UG scholar. His question is of 40 years pregnant women who is on immunosuppressants. He didn't specify the drug name, ma'am. And patient weight is 70 kgs with a TSH level of 10. How to manage this case?
As I've told you, pregnancy cases, kindly do not treat it with Ayurvedic medication. Refer them to contemporary and endocrinologist who will tackle the scenario, because as I've told you, the unborn child can later on develop with any developmental delays. So do not treat such case. Refer that case to endocrinologist.
Yeah, it was discussed in the previous slides, ma'am. Ma'am, next question is, did you encounter Pitta Prakopa Lakshanas while treating hypothyroidism with Varunadi, Chitrakadi, Kanchanara, etc. drugs? How to manage such Lakshanas?
I think it's a very good question. As I've told you, specifically whenever we use drugs like Pipali, the chances of having gastric irritation is quite common. But in conditions wherever we use Varunadi or Chitrakadi, the chances are very less. Advise the patient to have plenty of fluids. Second thing would be whenever you find that such instances are seen because of the Prakriti, all you can advise is probably instead of going it with the Chitrakadi Vati, you can go it with Shankavati and such preparations. So which basically does Dipana Pachana also, along with that does Pitta Shamana also. So for a brief period, you can shift from these drugs to, and you can even advise Avipatikara Churna also. So Avipatikara also does Dipana Pachana, has Trivrit Pitta Rechana occurs. So Amla Pitta features are also reduced, along with that Agni Dipana Pachana also occurs. So Trikatu and Trikatu is also one of the ingredient in the Trikatu, Trivrit, everything is an ingredient in Avipatikara Churna. So that can also be prescribed as an alternative instead of Chitrakadivati.
Another question, ma'am. Any external applications or lapas which are useful in goiter?
Okay, so there are a few preparations which are told in Samhitas, but practically I have not practiced it much, and I don't think so because see, you find metabolic changes over there when it comes to goiter presentation. So uses of that may be limited, is what I feel. So I don't personally practice any external applications for such cases.
Okay. I think there are few queries in the chat box, ma'am. Okay. When can we stop the medicines as there is recurrence after discontinuing the treatment?
See, as I've told you, it all depends whether the case is an autoimmune condition or not. In many autoimmune conditions, once we correct the Agni, there might be a brief period where patient might become completely asymptomatic, and we can withdraw for a brief period our medications also. But once again, explain the prognosis to the patient. There might be a case wherein there might be relapse if the patient doesn't follow the diet or lifestyle properly. But in non-autoimmune conditions, you can effectively treat and withdraw the Ayurvedic medications also.
Okay. Another question from the offline persons only. So, is Nasya Karma advisable in hypothyroidism and its role in hypothyroidism?
Yes, Nasya has been practiced, as I've told you, Kanchanara Swarasa Nasya is been told to regulate the hormone levels. So, plenty of studies are done on that. You can surely go ahead with Kanchanara Swarasa Nasya. But as I told you, it may not be a single line of management. Along with that, you may have to advise medications to correct the Agni.
Okay.
Then one more question. So when to decide then whether to prescribe T3, T4 test or when to go for FT3, FT4?
See, basically, you can surely go with regular T3, T4, and TSH can be advised to the patient. But the more accurate values you'll get it when you have feed T3, feed T4 values. So when you suspect any autoimmune conditions or when there is no much of clarity, you can go with the free T3 to free T4 values. That would give you more accurate values.
Okay. Any questions?
Thank you so much, ma'am, for such elaborate session. Your combined knowledge, Ayurveda knowledge along with practical application has truly enriched our knowledge. Personally, for me, it's truly a matter of gratitude and pride to have you as our speaker and also my guide throughout my PG journey. So, on behalf of our department, I heartful thank to you, ma'am. Now I call upon Dr. Karunakar Rao sir, our HOD, to deliver a vote of thanks, ma'am.
I would also like to thank the management of Rajareshwari Ayurveda Medical College and Hospital for giving this opportunity to share a bit of my experiences with maybe undergraduation and post-graduation students. And my special thanks to the HOD, Dr. Garunakar sir, and all the staff of Kaya Chikitsa Department of Rajareshwari Medical College. And special thanks to Dr. Gayatri. So she's been a very dear student of mine. So I think it's a, I feel very happy right now to be sharing. I'd rather seeing her as a student from that to shift to her to see as one of the, co-teacher or maybe a colleague. It feels very good. So thank you everyone for your patient listening.
Ma'am, thank you. Sir, you can deliver.
It gives immense pleasure to give you thanks, Madam, Dr. Priya Bhat. So you are saying today your student has become a faculty here and she has helped us to get you to teach our students today. We thank you for that. And we are happy to know a lot of information in the hypothyroidism and hyperthyroidism and other disorders and intervention through the Ayurvedic system. And so we are happy to hear all these things. And I hope our students, PG scholars, and some our faculty also got some knowledge through this. And we wish that in future to come with you for some more subjects to hear from you. Thank you very much. And even I worked in Hassan SDM in my early age. So happy to see you from the SDM and worked with the Prasanna sir. So and I thank our management, director, principal for giving us this opportunity to arrange this and also to participate in this. And I thank all my faculty and other teachers here who has participated and who gained the knowledge. And I also thank our PG scholars and students who has participated actively. And I hope they have noted down some of the information and which will be helpful for them in the coming days. Thank you, one and all. Thank you, Dr. Priya Bhat. Happy to see you and happy to hear. Thank you very much.
It's a pleasure interacting with you. Thank you.
Thank you.
Bye.